Incredibly, septicemia affects 50 million patients every year, and that accounts for 10 to 11 million deaths globally. For all of us, that translates as one family losing a loved one every 2 to 3 seconds.
In this episode, we examine the global burden of sepsis through the COVID-19 lens. We've got some of the top experts from around the world focusing on the practicalities of moving the needle, so to speak, in the fight against sepsis.
We're proud to collaborate with MSD on this educational project. MSD is committed to combating infectious diseases, to tackling antimicrobial resistance, and to coming up with new ways to face this current pandemic.
So wherever you are in the world, we ask that you take a moment to acknowledge the traditional custodians of the land on which you stand.
Welcome to Coda Zero.
So I'd like to now move on to Flavia. So Flavia, you've always had a very different perspective living in Brazil. And so from the recent Global Burden Disease paper, it states that the estimates of sepsis burden in LMICs are over 85%. So why is sepsis incidence disproportionately high in LMICs compared to high-income countries? And why is this same pattern not being seen in COVID?
Well, that's an interesting question. As you said, at the GBD study, we could see there was a higher incidence of sepsis in the settings where there is a lower social demographic index. Social demographic index is based on income, education, and fertility. And this is clear. And the impact of this in mortality, the difference, is even higher. So why? I believe that there are multiple factors related to the pathogen, related, for instance, we do have malaria, dengue, or infective agents with the host, for instance, undernutrition in Africa, and mostly the inequality in healthcare system. We know that inequality is present everywhere, but it's much hard in low and middle income countries. So we have differences in prevention strategies and clean water, sanitation, access to care, access to resources, education, training. All of these contribute not only to a higher incidence, but also and mostly to a higher mortality rates. And why this is not happening in COVID? It's quite interesting. We know that on the 50 top countries in COVID epidemiology, we have 6 high-income countries, and the top one is US. So maybe one of the issues is what we see. It is the pathogen. It's a transmissible disease. So the impact of the inequalities in healthcare system might not be so relevant. And of course, Simon mentioned that most of the sepsis cases are in people under 5 and in Africa. And why we're not seeing a disaster in Africa? It's a very good question. Why not? There are multiple explanations. The first one is testing. We are just not testing because it's most of them are low-income countries. They do not have money and a structure to test. But I haven't heard about a higher absolute numbers of deaths in Africa. So I don't think the issue is testing. Maybe it's because they have an early preparation and they have an up-down lockdown in many places. Maybe they are more used to this because they have fight Ebola. They have more tracking about the contacts. But I believe that probably it's just, again, inequality. The life expectancy in US is 79 years old, and the mean age is 38. The life expectancy in Africa is 64, and the mean age is 19. So, except from South Africa, that now has 500,000 cases. The second country is Nigeria, with around 40,000 cases. So except for the middle-income country over there, maybe they are not just living enough. to be so compromised by COVID. As we know, COVID, we have problems with mortality in those who have comorbidities and in aged people, and not in Africa. They die below the age of 5.
Thanks, Flavia. So if we can move on just to another question for you. So the COVID pandemic has exposed many vulnerabilities in all of the world's health systems. So for Brazil, from your experience, what are the key issues that COVID has highlighted in respects to vulnerabilities?
Yeah, I believe the first one I already mentioned is our high incidence of healthcare-related infections and multi-drug resistance. Maybe the second important issue is that it highlighted our high mortality for sepsis. And I do believe that COVID is just a viral sepsis. So it highlighted our high mortality rates. We already know that, but now everybody knows it, that people are dying from it. For instance, we have EpiMed in Brazil, which is a quality indicator program that it runs in hundreds of Brazilian ICUs. They track now more than 60,000 beds, and they have already in the database 23,000 COVID patients from the private system and around 10,000 patients from public system. So the first thing we see is that it's the difference in access. So the percentage of mechanical ventilated patients in the private unit is around 40%, and it's around 70% in the public ICUs. And the mortality rates, of course, are different. When you take all the ICUs into consideration, it's around 30% in private and 50% in public. But it's interesting to see, for instance, that when you took only the mechanical ventilated patients, it's around 60% in private and 70%. So it's not so different because we do face a very severely population. Another issue that we have now, as I already mentioned, is supplies. So we run out of noradrenaline, insulin, bicarbonate, propofol, midazolam, and this is also different. So it's not the problem that, for instance, in my hospital, they don't have money to buy. They don't have from whom to buy. And we are afraid that the access for buying things is also different from the private and from the public. So the sellers they can choose to whom they're going to sell. Another problem is the non-COVID track. So now, as Simon mentioned, it's much easier to get an ICU for a COVID patient in my hospital and in many hospitals in Brazil than a bed for a non-COVID patient. So the priority is so heavily weighted towards the COVID that we are losing more lives in the non-COVID track. And this is together with a lower, people are not seeking for care. They are staying at home because they are afraid of the hospitals. So they are much more sick when they finally arrive in our non-COVID track. And another big issue is that in middle-income countries, because of our religious practices, or maybe I don't know why, we are growing, we are improving in our capacity of doing end-of-life care. And now we were improving, and now we have COVID. So it's a weakness because we are not so good on that. And we need to learn, and we needed to learn fast because we have to make some choices. Well, and this is for the healthcare, but we do have another problems like our economy, fragility, corruption. Corruption is interesting. It's a plague in middle-income countries and also in low-income countries. And some hospital directors, they are afraid because they might be prosecuted in the future because they are paying 10 times, 20 times the price for the same supply about 6 months ago. So, and there is corruption, and they can be accused of corruption without being corrupted. So it's a huge problem. Not only talking about the lack of knowledge and political manipulation. I believe that anybody with an internet access knows about our president and all things that he has been doing in the last 5 months. So I believe that we had a lot of weakness that we could face at this moment. And we are trying to deal with all this.
Yeah. Thanks, Flavia. I think so. One of the audience questions is actually about how are politics affecting mortality in Brazil. I don't know if you want to make any statements on that at all.
Well, I don't believe that a single person can do so much harm. I mean, he is an unresponsible person, okay, but we do have state governments, we have the city people. So I think that we are dealing with this reasonably. So I do not blame the president or anything. I think he's just doing silly things, and we are taking care of people while he's doing silly.
Thanks, Flavia. Another audience question is, what is the basis of your diagnosis of secondary bacterial infections in COVID-19?
Well, that's a very difficult question. Well, it depends on where you are. Maybe procalcitonin helps us, PCR. But I would say that the thing that we most use to track a possible secondary infection is a worsening of the organ dysfunction. So it's when you're looking at the bedside and seeing the patient every day, you're going to see that he's getting worse. I don't know if any validation study of any biomarker that can differentiate secondary infection for worsening of COVID infection. This is a challenge that we will have to face. And let's see. And this is a problem because we certainly are overusing antibiotics.
Simon wants to butt in again.
Flavia, I have, as you know, I have enormous respect for you and for everyone in Brazil, having had the pleasure of visiting there a few times and seeing the struggles the public health system has at the best of times, let alone I can't imagine what it's like at the moment. I guess there was one issue around sepsis, and as I said, I think that we do have an opportunity. There are opportunities here. I mean, obviously, it's kind of seems a bit weird to be talking about the positives of a coronavirus pandemic, but there are opportunities here. And one of the things, you know, apart from the fact that, you know, now people have heard of ventilators, they've heard of intensive care, this mysterious place that you just see on the television. The other thing that's been quite heartening is to see in the popular press quite a bit of, certainly here, quite a bit of comment about the longer term effects, about how people are coming out of hospital but they're not actually healthy. They're not the person they were before. And again, Derek's been involved with this work as well of trying to highlight to people that sepsis is not just an acute event. You get treated, you leave hospital, and you're fine. The data says something completely different, that, you know, maybe a third of people who were working before they got sepsis and got treated in ICU for sepsis don't go back to work, or they certainly don't go back to the work they've done before. And we don't have systems to deal with that. So I think this is, again, one of the opportunities that's come out of COVID. And I guess maybe we've not got so much inequality there because we don't have any services for that in Australia. And I can imagine in Brazil it'd be even harder. But maybe there's an opportunity here for us to start highlighting, saying, you know, maybe it'll have to be after the pandemic that we say, okay, all those things you talked about and all those things you wanted to fix, they're still happening, but it's just not being caused by the coronavirus. How do we fix it?
That's a very good point, Simon. And I have a positive view of everything. I think there are some strengths that we have just recognizing now. For instance, just to mention one that is not related to your question, but for instance, philanthropy is something very strong in high-income countries. And it already exists in Brazil. But now we are seeing a completely different scenario. There are people donating a lot of money for the public health system. And we also have this that you mentioned, the recognition of the frontliners, the acknowledgement of what we're doing. Before that, when somebody asked me, oh, you're a doctor, what is your specialty? I said, intensive care. There are three options. Either they will say, what is intensive care? The second option, you're going to say, intensive care is a field of medicine. It's not just that something that any doctor can do. And the third one, we're going to say, oh, we are dealing with dead people. So now it's completely different. Now they know what is an intensive care team, what we do, and also the recognition of the public system support in this pandemic. It's a much, much better. About the long-term outcomes, as you know, Brazil was struggling to do this for the septic patients. There are some nice research in Brazil for this. And I remember well a meeting of ISF, the International Sepsis Meeting, where I was speaking about this. And then I sent a question for a lot of friends in low and middle income countries. And I asked them, what are you doing about long-term follow-up in septic patients? And they answered me, we're doing nothing. So we are trying to get them out of the hospital alive. So middle-income countries, low-income countries are in a different point of this from high-income countries. You already reduced your mortality rates. Now you're taking care of the survivors. We are still struggling to get them out of the hospital. And with COVID, remember, 70% of those mechanical ventilated patients are dying in hospitals that are able to fill data, but data infinite. So I agree with you that there is an opportunity here. As I said, now the numbers of deaths of this viral sepsis is much more recognized. Our role on this is much more recognized, but I'm not sure that we're going to be able to deal with specifically the long-term outcomes of COVID patients, although I agree it's a good opportunity to highlight this important issue.
Thank you, Flavia. I think we now need to wrap this up. I would have liked to ask you all a lot more questions, but we're running out of time. So thank you to our online audience for participating. A big thank you to our sponsor, MSD, for making this session possible. And an enormous thank you to our experts today for giving up your time and parting with your wisdom to leave us with a lot of food for thought. So thank you, stay safe and goodbye.